So the case that I was asked to present was a 68-year-old woman who presented with a 3-month history of intermittent abdominal pain and alternating constipation and diarrhea. She has a history of hypertension, hypercholesterolemia. This is well managed, as well as she's had a prior colonoscopy about 18 years ago at the age of 50, and that was unremarkable. She denies tobacco use and has no known family history of cancer. On examination, her abdomen was tender to deep palpation in the right lower quadrant. Her clinical workup included blood work. Her hemoglobin was 11.9, her hematocrit was 32%, her MCV was 75, and her CEA was 12.8. Diagnostic studies revealed, following a CT scan of the chest, abdomen, and pelvis, that she had a 5-centimeter right-sided mass with multiple liver metastasis and some associated adenopathy around the colon. Colonoscopy was eventually completed, noting the tumor in the ascending colon, and biopsy was completed. This was a non-obstructing tumor. The pathology was consistent with a poorly differentiated adenocarcinoma. A colonoscopy was completed on this patient, which revealed the tumor in the ascending colon. It was a non-obstructing tumor, and biopsies were completed. Pathology was consistent with a poorly differentiated adenocarcinoma. Biomarkers were sent off, including KRAS, NRAS, BRAF, MSI status, as well as NTRK. She was determined to be RAS wild type, BRAF wild type, MSI high, and NTRK positive. Based upon these diagnostic studies, her staging appears to be consistent with a TX-NX M1 tumor, and her ECOG performance status is 1. So my evaluation of this patient, who's an average age patient with what appears to be newly diagnosed stage 4 colorectal carcinoma. She has a non-obstructing tumor, so this does not indicate that she has to go to surgery. She's been determined to have an MSI high tumor, which is obviously a good prognostic sign for this patient. But more importantly, she also has been found to have other molecular markers, which are also favorable in the sense that she is all RAS wild type, but she's also determined to be NTRK positive. So this is the type of patient that we would proceed with systemic chemotherapy or systemic treatment versus proceeding with any type of surgical intervention. So the incidence of an NTRK fusion in colorectal carcinoma is extremely rare. It is probably less than 1% of all of our colorectal cancer patients. It's actually been evaluated based upon analysis completed by CARIS, which noted that of 11,000 patients that they evaluated, it was present in about 0.23% of all patients. However, there appears to be an increased incidence in MSI high patients. In regards to the prognosis of these patients, much of the data is still very immature. But I would say, depending upon whether or not the patients had prior therapy and take into account whether they are MSI high or MSI stable, that also determines their overall prognosis. So in this patient that's newly diagnosed, obviously they do have different options, but more importantly, she is MSI high, which also allows the opportunity for the role of immunotherapy as well.